Hello and welcome to our attendees here in the U.S. and around the world. Thank you for joining us for today's Nova Biomedical webinar, Ionized or Total Magnesium Levels, What Should We Measure in Critically Ill Patients? Our speaker today is Dr. Abdullah Alawi, Senior Consultant, UMC, in Muscat, Oman, and Program Director of the Internal Medicine Residency Program at the Sultan Qaboos University Department of Medicine. Also presenting will be Dr. Dennis Beagos from Nova's Medical and Scientific Affairs Department, who will discuss ionized magnesium assessment in critically ill patients. I'm Rick Rollins, Senior Marketing Manager at Nova, moderator of today's event. To take part in the discussion, you can post questions during the webinar using the Ask a Question tab on your webinar console. We will address questions following the main presentations, and a full list of questions and answers will be provided to you soon after the webcast. This webinar has been approved for 1 contact hour of PACE Continuing Education credit and 1 CERP unit by the American Association of Critical Care Nurses. You can obtain your CE certificate by completing the post-webinar survey that will be sent following the conclusion of the webinar. If you fail to receive the survey, please be sure to check your junk mail folders in your email system. Please note that credits are available for 1 year after the initial airing of this webinar. You can register for future live events on the Nova website and explore our broad library of on-demand content with topics ranging from clinical and veterinary diagnostic testing to cell culture testing in biotech and pharmaceuticals. Be sure to subscribe to receive notice of future Nova educational webinars. You can also find more information about whole blood critical care testing products on the Nova website. And now on to our main presentation. Dr. Abdullah Alawi obtained his BS and medical degrees from Sultan Qaboos University in Oman. Subsequently, he performed acute care and general medicine training in Australia and was awarded a fellowship in the Royal Australasian College of Physicians. He also obtained a master's degree in clinical epidemiology from the University of Newcastle in Australia. At present, Abdullah is working as a full-time physician at Sultan Qaboos University Hospital in Oman. He has special interest in the management of patients with complex diseases and in medical education and research. Please welcome Dr. Alawi.
Thank you, Rick. My name is Abdullah Alawi, Senior Consultant Physician. I work at University Medical City, and I have done several research around magnesium. Our topic today is ionized magnesium in critical care setting. In our presentation, I'm going to cover several points. Briefly, we'll mention about magnesium and human body, and then we'll talk briefly about ionized magnesium versus total magnesium. I will elaborate in a topic of ionized hypomagnesemia in critical care setting. Also, we'll touch base on ionized hypermagnesemia, and we will share some of preliminary study findings of our study that we have done about ionized magnesium in intensive care unit setting, and I'll propose a future research direction. Magnesium is very important, essential ion in human body, and it is the 4th most abundant cation. It is available in several foods that humans consume daily, and it got absorbed in the small intestine, and part of it excreted through the kidneys. However, the excess amount also got excreted by intestine. The vast majority of magnesium, after being absorbed in the human, it goes to the muscle and the bone, and only around 1% is available in the blood. And the normal total magnesium level in human body range between 0.7 to 1 millimole per liter. It is very important. Magnesium plays very important roles in human body, and almost it is involved in every physiological process. And it was estimated that around 300 enzymatic reactions, including those involved in energy metabolism, protein synthesis, ATP, and others, are dependent on magnesium. Also, it affects transportation of other essential ions like potassium, calcium, and modulate single transduction and cell proliferation. It involves in all practically body like cardiovascular, neurological system, kidneys, gastrointestinal, and many studies have confirmed that dysmagnesemia or abnormal magnesium level in human body associated with many poor health outcomes. This is just an overview about the importance of magnesium in important body system. In neurological system, magnesium plays a significant role in transmission, and several studies has confirmed that abnormal magnesium level was associated with migraine, depression, epilepsy, Alzheimer, and Parkinson's disease. Also, magnesium plays a very important role when it comes to treatment and conditions like preeclampsia. Now, standardized protocol include intravenous magnesium as essential part of prevention and treatment. Cardiovascular, magnesium has very important role into neural excitation, cardiac conduction, and it is well known that hypomagnesemia associated with very serious arrhythmia, including atrial fibrillation, ventricular arrhythmia, and magnesium also is included as a part of SELS when dealing with certain arrhythmia, including ventricular tachycardia. Which one is more important? Is it ionized magnesium or total magnesium? First of all, we need to understand, as we mentioned, only 1% of total body magnesium remain in blood. And out of this 1%, 25% is bound to albumin, and another 8% complex with anions. And that will leave around 70% of total magnesium free as bioactive ionized form. And this is the active form of magnesium. And several studies has suggested that ionized magnesium, it is more sensitive and reliable marker, especially during time of critical illness and among patients who were admitted to intensive care unit or high dependency unit. Also, when it comes to measuring magnesium in critical care setting, studies have shown that there was weak correlation between total magnesium and ionized magnesium level. And as high as 80% of what remarked as low total magnesium values were found to be false hypomagnesemia when it's compared to ionized magnesium measurement. And that definitely can lead to unnecessary testing and replacement. In addition, in acute care setting, specifically intensive care unit, precise magnesium level are necessary to effective treatment in many conditions, including cardiac arrhythmia, other conditions like seizure, and many other important clinical diagnoses. There are several studies which conducted to measure the prevalence of dysmagnesemia among critically sick patients. And in conclusion, it is very common. It was estimated that the prevalence of hypomagnesemia ranged between 8.5 to 21%. And that big variation in the prevalence of hypomagnesemia in critical care setting will be explained by different population being studied, or that underlying condition, or certain medication use. And we can mention, for example, proton pump inhibitor like esomeprazole, which is commonly prescribed in intensive care unit, can be associated with severe form of hypomagnesemia. Also, the severity of illness and the underlying health condition. And again, also the prevalence of acute kidney injury, which might be associated with hypermagnesemia in that setting. Beside the clinical diagnosis and clinical reason for variation in prevalence of hypomagnesemia, there are non-clinical causes for those differences, and they are more apparent when it comes to ionized magnesium. I will mention some of them. For example, ionized magnesium reference range. It is not well established, and there are certain studies done in different populations and reported difference cut-off limit for what regarded as normal ionized magnesium level. So some studies reported the lower cut-off limit of 0.44, while other study reported cut-off value of 0.51, and similar discrepancies exist in the upper limit of ionized magnesium. And when we go to literature, we find different populations has different normal range of ionized magnesium. Also, till now, ionized magnesium not commonly used in clinical practice as common as total magnesium. And sample variation like measuring ionized magnesium from plasma versus serum that can lead to differences in the reported range of ionized magnesium. Same as the different techniques used, and also how fast we process a sample. So all this led to variation in the reported prevalence of hypomagnesemia. However, when it comes to clinical setting, there are many reasons why patients develop hypomagnesemia. First of all, reduced intestinal absorption as a result for being critically sick, increased gut edema, or the use of opioids or other narcotic medication, either for pain management or for sedation. Nasogastric suction, which is very common among critically sick patients due to slow gastric emptying. Also, insufficient magnesium content in total parenteral nutrition, and the use of certain medication, as I mentioned, one of them a proton pump inhibitor and other antibiotics, specifically aminoglycosides, diuretics, and others. Also, ionized hypomagnesemia is more common in certain diagnoses. For example, sepsis for patient who has a pre-existing chronic condition like hypertension, diabetes mellitus, or other. So what is the significance of ionized hypomagnesemia in critical care setting? There are good body of literature done around ionized hypomagnesemia in critical care setting, and studies showed that ionized hypomagnesemia associated with increased mortality, prolonged length of hospital stay, increased the need for mechanical ventilation, increased risk of sepsis, and other poor health outcomes, including also increased rate of hospital readmission. In contrast, hypermagnesemia, it is not well studied as hypomagnesemia, and the reported prevalence of ionized hypermagnesemia in critical care setting range from 14 to 23.6%. And we can quote the same example, which is different population included in the studies, or different techniques used to assess the level of magnesium, or different range could potentially attribute to the variation in the prevalence of hypermagnesemia in critical care setting. And it is more common among the patient with renal failure. However, as I mentioned, it is poorly studied, but again, hypermagnesemia reported to be associated with other poor healthcare outcomes. In the following slides, I would like to share the finding of our study that we have conducted at University Medical City. And basically, prospectively, we looked into the patient who were admitted to intensive care unit and high dependency unit. And we have measured their total and ionized magnesium level. And we have gathered a lot of data related to their demographics, comorbidities, their clinical profile, including laboratory and hematological measurements, detailed health outcomes, including length of hospital stay, and many other outcomes. And the main objective of the study was to determine the prevalence of dysmagnesemia among critically ill patients. And what I mean by dysmagnesemia, it is variation of magnesium level, either low, so it is hypomagnesemia, or high, which is hypermagnesemia. And we were trying to see whether dysmagnesemia was associated with any of the following health outcomes, including length of hospital stay, stay in intensive care unit, in hospital mortality, the time needed to be in ventilator, cardiovascular event, and specifically arrhythmias, including atrial fibrillation, ventricular fibrillation, the rate of hospital readmission in 90 days, and mortality in 90 days. So it was a prospective cohort study done at Sultan Qaboos University Hospital, which is part of University Medical City. And we included all adult patients who were admitted to the intensive care unit between February and December 2023. So it is fairly very new study. And in fact, we have submitted it for publication, and hopefully will be available in literature over the next few months. So what we have done for our assessment of ionized magnesium, we use analyzer with electrolyte provided by Data Profile Prime Plus, the name of the machine, and it is supplied by Nova Biomedical, and this is specifically supplied for research purpose. The research being sponsored by Minister of Higher Education, and neither of sponsor has intervention in our protocols, so it was a very objective process. The total concentration of magnesium was assessed using colorimetric endpoint reactions, and we define ionized hypomagnesemia as the range less than or equal 0.46 millimole per liter. And this is actually done after we establish a reference range for Omani population, and we have published this result in Journal of Biomedicine. And also we define ionized hypomagnesemia if the patient has ionized magnesium level more than 0.69 millimole per liter. So when it comes to total magnesium definition, it was defined using the laboratory finding which define hypoglycemia if the patient has concentration of total magnesium less than or equal 0.69 millimole per liter, or patient will label as having a total hypermagnesemia if his total magnesium level was more than 1.01 millimole per liter. So we use this definition, and it was specific for our local population. So we included 134 patients, and understanding they are critically sick patients admitted to intensive care unit in tertiary hospital. This is considered to be a good sample size. A lot of other studies actually use similar sample size. And we employ person correlation coefficient between ionized magnesium and total magnesium concentration to see whether they are correlating. And actually it showed that it was very weak correlation between ionized magnesium level and total magnesium level in critically sick patients. What about the prevalence of hypoglycemia, which was the primary objective in our study? So the prevalence of hypoglycemia was 6.72%, and the prevalence of ionized hypermagnesemia was 39.55%. When it comes to definition using total magnesium, the prevalence of hypoglycemia was 14.93%, and the prevalence of hypoglycemia 22.39%. So we can see there is a discrepancy between hypoglycemia reported using ionized magnesium level versus total magnesium level. Same as hypermagnesemia, there are differences in the prevalence if we use ionized magnesium level compared to total magnesium level. Also, we try to correlate between the concentration of magnesium and the level of albumin. And the reason for running that association, because we understand that 25% of total magnesium is bound to albumin. However, nor total magnesium was showing good relation when it comes to albumin. And that probably indicate there is other things which is acidity or change in the pH might play effect on the actual level of magnesium, and that hence cause some discrepancy between both measurements. This is very busy table. However, I would summarize it. So this is dictating patient characteristic, patient profile in terms of comorbidities, and also you can see the medication used. So in the second column in the left, we can see the total number of the patients. So we have 134 patients, and we classify patient according to their level of ionized magnesium. So the first category, ionized hypomagnesemia, defined by magnesium less than or equal 0.46 millimole per liter. And we have patients in the middle column, which is having the patient with normal ionized magnesium, and that define any value between 0.47 to 0.68 millimole per liter. And again, we have in the second last column, including the patient with ionized hypermagnesemia, and that defined by magnesium level more than or equal 0.69 millimole per liter. So what we can see in the table, we can see there is patient who has some diagnosis, for example, diabetic ketoacidosis. They tend to have lower ionized magnesium level. However, when it comes to other comorbidities, age, gender of the patient, and other things, there is no significant p-value. This is a very important table, and basically here we are trying to link derangement in magnesium, whether it is hypomagnesemia or hypermagnesemia, with poor healthcare outcomes. And as we can see, we included very important health parameters, including length of hospital stay, stay in intensive care unit or high dependency, time required to be in ventilator, seizure, atrial fibrillation, and other parameters like, for example, in hospital mortality, 90 days mortality, and ICU readmission. And as we can see clearly in this table, hypomagnesemia correlate or associate with increased rate of atrial fibrillation or all other type of arrhythmia, and it was a very significant p-value. Also, we have done survival analysis using Kaplan-Meier analysis, and basically we're trying to see whether dysmagnesemia, which is including both hypo and hypermagnesemia, associate with increased all-cause of mortality. And in the survival analysis, as we can see, there is no significant difference in hospital or 90 days mortality among patients using their total ionized magnesium. So we have demonstrated in our result there was a weak positive linear relationship between ionized magnesium and total magnesium concentration. So basically, they don't correlate well, specifically in intensive care unit setting. And that can be a result because of low albumin levels or change in acidity or the rapid change in level of magnesium, because there is like rapid change in hemodynamic of patients, specifically when they are being in intensive care unit. In fact, this is one of the few studies that look into that correlation. And having this study, it is consolidate our understanding how ionized magnesium poorly associated with total magnesium level when it comes to patients who are admitted to intensive care unit. The correlation might be affected by several factors, as I mentioned, several of them. In addition to that, also tissue damage, dietary intake, and severe illness, and that probably causing all this discrepancy between total ionized magnesium level. The hypomagnesemia prevalence in our study measured by ionized magnesium was 6.72, which is almost similar to area reported study, which indicated that hypomagnesemia, as we mentioned earlier, varies between 9.7 to 14.4%. However, our study found that there was a higher prevalence of hypomagnesemia when it comes to our patients, and it was very prevalent. Like 39.55 of our patients, they had ionized hypermagnesemia. And we are not entirely sure why this happened, but probably this findings due to the different definition of reference range, or maybe because a lot of this patient received unnecessarily intravenous magnesium replacement because their total magnesium was incorrectly reported low. And as I mentioned, actually, all patient actual treatment in terms of magnesium level was guided by using total magnesium level in our population, and ionized magnesium was done specific just for research purpose. As we mentioned, they are present for having some differences between the prevalence of dysmagnesemia among different ICU settings, and that include many factors, including the severity of the illness. Also, the difference in standardizing the definition and measurement techniques for ionized magnesium. Previous research also indicated a negative and positive correlation when it comes to ionized and total magnesium. However, we have seen very poor, weak association between ionized and total magnesium there. And a substantial part of serum magnesium bind to albumin, indicating critical role of albumin in managing magnesium level, and direct measurement is necessary to accurately determine level. So we should not rely in total magnesium measurement to conclude what ionized magnesium level could be in our critical sick patients. Also, our study demonstrated that using ionized magnesium concentration, hypomagnesium was associated with significant risk of cardiac arrhythmia, including atrial fibrillation. And this finding is consistent with some other previous study findings which link hypomagnesium with increased risk of arrhythmia. Previous study has indicated also link between hypoglycemia and increased mortality, long length of hospital stay, septic shock, and increased need for ventilation. But we could not demonstrate this association, and I guess that's probably because of small sample size, which was 134. So in summary, dysmagnesemia is very common among critically ill patients, and ionized magnesium level does not correlate with total magnesium level in critical care setting. And we have demonstrated significant association between hypomagnesemia when measured by using ionized magnesium and arrhythmia. And in a table that I have not shared, most of patients with hypomagnesemia as measured by ionized magnesium did not receive magnesium replacement because we use total magnesium level to guide the treatment in our care. However, things might change in the future as there are very good evidence of research accumulating indicating the importance of measuring ionized magnesium instead of total magnesium, specifically in critical care setting. So what our next step in trying to find the better way to approach magnesium disorders in critical care setting, we will use, we'll do another study using larger sample size. However, our next study will be a trial, and that basically will be replacing magnesium in critical sick patient using ionized magnesium level instead of total. And hopefully we can demonstrate there is some health care benefit by maintaining normal magnesium level in critical sick patients, or reduce the time required for ventilation. This concludes my presentation. Thank you very much.
Thank you, Dr. Alawi, for that insightful presentation. You make a good case for standardizing the definitions and measurement techniques for ionized magnesium to support the management of this common electrolyte imbalance. Now, Dr. Dennis Beagos will discuss the assessment of ionized magnesium disorders common in critically ill patients. Dennis?
Thanks, Rick, and I also wanted to thank Dr. Alawi for an excellent presentation and for the research that he's doing on ionized magnesium and recognizing the importance of magnesium in patients' health, especially in critically ill patients. Today, I wanted to talk a little bit more about the importance of measuring ionized magnesium and using ionized magnesium in decision-making for critically ill patients in particular. Magnesium in general for a long time has been poorly understood. It's been called the forgotten electrolyte or the forgotten mineral. And fortunately now it's becoming more recognized as important in health and disease. We have journals devoted specifically to magnesium research. We have societies, international societies devoted to magnesium research with international symposiums and discussions on magnesium in health and disease. So it's really now getting its due as the electrolyte that it, getting the due that it deserves. And one of the things I wanted to focus on during this talk is that we'll see a lot of research where ionized magnesium and total magnesium correlate with each other, and that's understandable. They're measuring basically the same electrolyte, but correlation does not necessarily equal category agreement. And you can see in this slide here the correlation between ionized magnesium and total magnesium, ionized magnesium on the y-axis, total magnesium on the x-axis, is good. It's 0.88. But there's a significant number of patients, which you can see in the red squares here, where the category agreement does not line up. In this case, it's roughly 30% of patients who have a discrepancy between their total magnesium and ionized magnesium when you're looking at hypomagnesemia or hypermagnesemia. And this can be important, especially in critically ill patients who are the most vulnerable patients and whose magnesium status is something that's critical to their care. And we see this again and again. So this is a study from Sweden showing that roughly 35% of patients have a discrepancy in terms of their category agreement between ionized magnesium and total magnesium. And this is in a strictly ICU population. Again, another ICU study showing that about 30% of patients don't have category agreement between total magnesium and ionized magnesium. And actually, in this particular case, you can see in the red boxes where the total magnesium and ionized magnesium category agreement doesn't match up. And they felt that in a lot of the authors of this study felt that in a significant number of these patients, this could lead to cost savings and pharmacy savings in terms of managing these patients, because a lot of the patients who had low total magnesium actually had normal ionized magnesium, and this would have allowed them to decrease the number of blood draws, decrease the amount of magnesium that these patients were given. This isn't consistent among studies, so some studies show the opposite, but most studies show this number, roughly around 30 to 35% of patients whose category agreement does not line up. So this discrepancy can also particularly be seen in certain subgroups of patients, and this is a study that was done in patients receiving continuous veno-veno hemofiltration, or CVVH, and those patients were getting citrate as an anticoagulant. And we all know that citrate works to anticoagulate patients by binding calcium, but magnesium, being a divalent cation, is also bound to citrate. And in those patients, the citrate and magnesium complex is measured in the total magnesium. So the total magnesium might be normal, but as you can see in the outlined area here in red, patients who are on citrate, their ionized magnesium is significantly lower. So this is an important subgroup of patients where ionized magnesium is far superior than total magnesium in assessing a patient's magnesium status. You can also see here the pharmacokinetics of ionized magnesium. This is a study that was done and published in 2018, looking at 32 patients, children with asthma, getting intravenous magnesium sulfate, and they measured total magnesium versus ionized magnesium. They found the ratio of ionized magnesium to total magnesium was around 35%. But if you look at the graph on the right, the blue dots and bars represent the levels of total magnesium, whereas the red bar and dots below represent ionized magnesium. And you can see that the ionized magnesium range and levels are much tighter, so it's a much more valid indicator of a patient's magnesium status than the total magnesium, which has a very broad range of values. And it's all well and good to know that category agreement is different among total magnesium and ionized magnesium. What about clinical outcomes and variables related to the differences between ionized magnesium and total magnesium? That's what's really important. And this is a study done way back in 1993, looking at ionized magnesium both before and after coronary bypass in patients undergoing cardiac surgery. It's a small study of only 20 patients, but they found that there was a significant reduction in ionized magnesium on post-op day 1 when those patients had a normal total magnesium. And therefore, those patients possibly would not have received appropriate magnesium supplementation, potentially more susceptible to cardiac arrhythmias related to that. In children, we can see the same thing. This is a study from 1998 looking at 67 patients in the pediatric ICU as well as 24 healthy controls. It's not surprising that the ionized magnesium level was lower in ICU patients than in control patients. And what's important is that if you look at the pie chart here on the right, all these patients in the pie chart had normal total magnesium, but 60% of them had low ionized magnesium. So total magnesium, again, is not a good indicator of patients' magnesium status. Let's talk a little more about outcomes. Another study looking at pediatric cardiac surgery patients, 181 patients, and they measured ionized magnesium across the course of their perioperative care. So preoperatively, during cardiopulmonary bypass, after cardiopulmonary bypass, and then in the ICU. And they looked at patients who had low ionized magnesium versus patients who had normal ionized magnesium. And you can see in the graph on the right that patients with normal ionized magnesium had better outcomes. They had lower PRISM scores, they had fewer days on the ventilator, and a shorter stay in the ICU than patients who had low ionized magnesium. Another study done on cardiac surgery patients, looking at 85 patients, and they decided to dose their magnesium replacement based on ionized magnesium values. And patients who had their magnesium dosed based on IMAG levels versus controls show that there were fewer episodes of ventricular tachycardia in this group. More patients remained in normal sinus rhythm, and there was a trend towards less supraventricular tachycardia, although this trend did not reach significance. But again, it was a small study, not powered necessarily to achieve that. Here's another example. This is just a case study of a patient who was treated with magnesium for torsades, a patient who received 6 grams of intravenous magnesium for torsades, which is a cardiac arrhythmia generally treated with generally treated with magnesium infusion. The patient did not break after 6 grams of IV magnesium and therefore was transferred to an ICU where they could be managed with ionized magnesium levels. And the patient had a magnesium drip that was titrated to a specific ionized magnesium level. And that target was achieved in 90 minutes, and at that point the torsades was stopped. And the authors stated that the lengthy turnaround time of total magnesium is unsuitable, whereas ionized magnesium is superior for critically ill patients under time-sensitive situations, such as in the ICU. Ionized magnesium is an especially useful parameter for proper dose adjustment and for the early detection of abnormal values. So the speed of turnaround time of ionized magnesium, which is approximately a minute, can help give you real-time results and allow you to titrate doses of magnesium infusions. This can be helpful not just in cardiac patients or in ICU patients, but, for example, patients with preeclampsia who are getting magnesium infusions as well, and other patients who might be getting magnesium. This is a study from Japan looking at atrial fibrillation following esophagectomy, published in 2021. It was a retrospective review, and they looked at some of the factors that were associated with atrial fibrillation following esophagectomy. You can see that ionized magnesium levels before surgery were measured as either low or normal, and patients who had low ionized magnesium levels had a higher rate of postoperative atrial fibrillation. So ionized magnesium may be useful in triaging patients who could be at high risk for atrial fibrillation and potentially treating patients with magnesium if they come in with a low magnesium level to potentially prevent post-op atrial fibrillation. And there's a study that's being started to examine just this. This is a protocol from the Netherlands where they're going to be dosing magnesium supplementation in cardiac surgery patients based on their ionized magnesium level and trying to see if there is a lower rate of atrial fibrillation postoperatively in this patient group. There are a lot of benefits to using ionized magnesium, which hopefully I've shown. Firstly, there's real-time results. You get the results in less than a minute, and this can be used to make real-time patient care decisions. It can be used for things like titrating infusions, like we saw in the one study, both in the ICU and on the OB ward for patients with preeclampsia. At times, even though patients are given large doses of magnesium, that may not be enough in certain patients, so one size doesn't fit all. So patients may be getting what clinicians think is an appropriate dose of magnesium, but this may not be enough. So patients with persistent arrhythmias, again, like the case study that we saw, patients who have hypokalemia, and magnesium is a known factor in potassium metabolism, so patients with hypomagnesemia will often have refractory hypokalemia. And these are times when time is critical, and especially in critically ill patients, it's important to get your results as quickly as possible. So we know that taking care of critically ill patients relies on precision and accuracy, so it makes sense to be using the best available and most rapidly available data in caring for these patients. This is our Prime Plus device, which is able to measure ionized magnesium in addition to multiple other measured and calculated parameters. And again, results for ionized magnesium and all the other factors are obtained in approximately a minute. And this can be done essentially in the ICU in real time. So to summarize, ionized magnesium is the physiologically active component of magnesium in the body, in the bloodstream. Total magnesium and ionized magnesium may correlate, but category agreement is more important than correlation, and category agreement in general is poor, showing about a 30 to 35% discrepancy in terms of magnesium status. For this reason, I think ionized magnesium is a preferred measure of magnesium status. And rapid determination of ionized magnesium levels may facilitate decision-making in a number of settings. So it could be in cardiology and cardiac surgery, either in the operating room or in the cardiac ICU, in the emergency department, in other critically ill patients and in the ICU, patients on the obstetric ward with preeclampsia, specifically patients with asthma in the emergency department also can benefit from ionized magnesium levels to determine appropriate dosage of magnesium. So ionized magnesium measurement may improve patient care in these settings, and more research is underway to determine whether this is the case. And hopefully, as time goes on, we'll have better outcomes data regarding utilizing ionized magnesium in clinical decision-making, especially in critically ill patients. So thank you for attending this webinar and for your attention here. I wanted to again thank Dr. Alawi for his expertise and his research in the area. We're really very fortunate to have a researcher of his magnitude to present this webinar. I wanted to also thank Rick Rollins for hosting. If you have any questions and you're watching this live, you can feel free to submit them through the portal. If you're not watching this live, or if we don't get to your questions, please feel free to email me any questions you might have on the email address that you see on the screen. And thanks again, and I'll turn it back over to Rick.
Thank you, Dennis. Now, before we begin the question and answer session, I want to remind you to submit questions for Dr. Alawi and Dr. Beagos using the Q&A tab on your screen. Also, as a reminder, your continuing education certificates will be emailed once you complete the post-webinar survey. A link will be sent to you soon after the conclusion of the webinar. Now we have a few questions for Dr. Alawi. Our first question: some studies have shown a stronger correlation between ionized magnesium and total magnesium among critical ICU patients, but a weaker correlation in non-critical patients. Your study showed a weak correlation in critical patients. What are your thoughts on this correlation among non-critical patients?
Okay, so when it comes to critical care setting, one of the important things for clinician to understand when the patient population who are admitted in critical care setting they are of different categories. We find some intensive care units, they have very critical sick patients, and some of them they have like specific category, like mainly cardiac patient, while the other they have mix of general patients which including sepsis, and that affects a lot of things, affecting first of all acidity, albumin level, and other things, and that probably resulted in variation into how total magnesium and ionized magnesium correlate to each other. When it comes to our critical sick patients, like our ICU, we admitted the very critical. We are working in tertiary hospital. Our category of patients, they are very critical. Like normally they have been intubated, double vasopressors. Mortality rate is very high because they are critically sick. They have normally multi-drug resistant. We received this patient actually from other regional hospital from the whole Oman. So that probably has played a part into these findings. However, we have to admit the sample size that we use 134, and that probably also impacted in the final outcome.
Okay, thank you for that answer. Next, do you think ionized magnesium is a better marker of magnesium status in patients with CKD? How about in dialysis patients?
Okay, so when it comes to people who has acute kidney injury or chronic kidney disease, they tend to accumulate magnesium in the blood because of impaired excretion of magnesium. However, the same concept remain, which is ionized magnesium will provide more accurate and precise value of the actual magnesium level in this population. Because again, whether they have chronic kidney disease or acute kidney injury, being admitted to intensive care unit, that affect a lot of things, including their level of albumin, the acidity, and that definitely will impact into the value of total magnesium. So my personal thought, based on extensive literature that we have conducted, and being a researcher, we have done several research either in Oman or Australia. We advocate for the use of ionized magnesium.
Okay, thank you. Our next question, what are the advantages of using a point-of-care measurement of ionized magnesium versus total magnesium from the central lab?
So the way how it's done, point of care, it is the machine itself that we use in the research. It is can be a part of medical ward or intensive care unit. In fact, we have used one of the machine in OPD setting, and it is very easy to calibrate. It requires 1 ml of blood using the standard heparinized syringe that normally used for ABG, and that can give you actually very quick measurement of magnesium value, and that's very relevant if you have a critically hospitalized patient, and then patient run into atrial fibrillation or other arrhythmia, which is very common, and that will give you a hint what is their magnesium level, so you can replace that one. Using the total magnesium level, that at least will require, I would say, 1 to 2 hours to get the value. And by that time, your patient might receive intervention or he might suffer of complication. So to have prompt, immediate answer that give you magnesium value, ionized magnesium is the way to go. And then if you replace your patient with, say, for example, 1 gram of intravenous magnesium sulfate, then you have the opportunity to check it again using just 1 ml of blood, while that is not possible using total magnesium.
We have time for one more question. Can you discuss the differences in outcomes in those patients treated based on ionized magnesium versus total magnesium?
So, like many other intensive care units, unfortunately, ionized magnesium is still not standardized part of clinical practice. And that is probably to a lot of reasons. First of all, total magnesium, it was very common. It is most of the previous study was done on it, but ionized magnesium is a very new concept. So in our study, actually, what happened, still the standard things which is used to assess the magnesium status was total magnesium level. And that was guiding the physician to decide whether to replace magnesium or not to replace. We have to use ionized magnesium just to see the level. And what we have concluded, there was discrepancy. Like there was no correlation, and some patients who were labeled having high magnesium using total, they were in fact sufficient in magnesium and vice versa. And that resulted into a fact, some patients who didn't require magnesium, they got a replacement because their measurement was done using total magnesium. And some people who were required magnesium didn't receive it because their laboratory tests indicating they have sufficient magnesium because it was measured using total magnesium. So that created probably some patient abandoned from receiving the adequate magnesium level. So as I mentioned, our next study will try to segregate, to do a trial, because at the moment we have like ethical basis to conduct a trial. So we'll continue. One arm of the trial will be continuing receiving magnesium replacement according to the total magnesium. However, the other arm, which will be the actual intervention arm, will receive replacement of ionized magnesium level. So we'll supply the patient with intravenous magnesium to maintain the level of ionized magnesium above 0.46 millimole per liter. And based on brief literature or understanding the clinical physiology of magnesium, we hope to see some health benefit, either by improving some survival of the patient or reducing their need to stay in intensive care unit.
Okay, thank you to our audience for those excellent questions. We will conclude the webinar at this point, but be sure to join us again and invite your colleagues to attend the next Nova Biomedical educational webinar. You can register at novabiomedical.com/webinars, where you'll also find a full catalog of on-demand webinar offerings. So for Dr. Alawi and Dr. Beagos, I want to thank you for your attention and interest, and enjoy the rest of your day.